And we're very fortunate to have Margo Gallegos from Ambry Genetics, one of the largest and one of the best genetic testing centers in the United States. She's gotten her degree in genetic testing from MUSC, which is near and dear to my heart for reasons that are I won't go into right now. But she'll tell you about what genetic testing is and what it does from the point of view of a clinical practitioner, and how it's going to kind of help drive the future in autism and other pediatric onset disorders. Please welcome Margo Gallegos.
Hi, everybody. Thank you so much for having me today. So today I am going to be talking about, as you mentioned, exome testing, which is a test that now is used regularly by many clinics and many individuals who are presenting with neurodevelopment disorders, including autism. So I'm just going to talk about Ambry Genetics and how we approach autism, or genetic testing for autism. So a little bit about Ambry before I go into the specifics. So Ambry actually was the first to launch whole exome sequencing in 2011. So when I first became a genetic counselor over a decade ago, whole exome sequencing was very new, and it cost upwards of $12,000. Now, and really insurance didn't cover it. It was very hard to get done on a regular basis, and not a lot of labs offered it. Ambry, as I mentioned, was the first to launch it, and now I am very happy to say that testing has come down quite drastically in price, making testing much more accessible to patients. Insurance coverage is really great. I'm going to talk a little bit about that, and the guidelines recommend whole exome sequencing as a first-line test. Perfect. So first we're going to be talking about the clinical benefit of testing using exome for patients with autism. We're next going to talk about how interpretation changes over time and the impact of positive results on management. But I like to start with cases because as I mentioned, I was in clinic for many years. I worked in a general genetics clinic at Children's National Medical Center in Washington, D.C., and I would say this is a very typical presentation of a patient. So this was a 3.5-year-old girl. So she presented with multiple different body systems affected. So she had scoliosis and low muscle tone, also called hypotonia. She also had abnormal movements and dystonia. She had developmental delay and autism, but had a normal EEG as well as a normal brain MRI. She had eye abnormalities as well as pretty severe feeding difficulties, including a G-tube. So her provider, taking a look at multiple body systems affected, having a diagnosis of autism and developmental delay, said, I think this could be genetic, and started the genetic testing workflow. At that time, a chromosome microarray was pretty much a first-line test, and a chromosome microarray is looking at the packages that hold the genetic information, looking for extra missing pieces. That has a diagnostic yield by around 15%. And so they ordered a chromosome microarray. It was negative. They ordered Fragile X testing. It was also negative. That's a very common genetic disorder that can cause autism in both boys and girls. And they also ordered MECP2 testing because of the abnormal movement, so testing for Rett syndrome, and that was negative. So they decided to order an exome. So when we talk a little bit about genetic testing in the clinical setting, providers follow guidelines. So the most common guidelines are the American College of Medical Genetics, also called ACMG. And up until about 2021, the first-line test for autism and developmental delay was that chromosome microarray that I talked about. However, 85% of patients didn't get a diagnosis from that testing. And then Next often would be panel testing, which I'll talk a little bit about the difference between exome and panels in the next slide. But panel testing really isn't as useful as whole exome sequencing. And so that is the reason why in 2021, the American College of Medical Genetics said, it is very reasonable to start with this very broad testing methodology because it has between a 25 and 40% diagnostic yield comparative to, depending on the lab that you're using, compared to that 15% diagnostic yield, or even a 3% diagnostic yield from a chromosome karyotype, which is that picture of the chromosomes. And so they said, has great diagnostic yield, it's come down pretty well in price, so now it's a reasonable price point for patients. Most payers actually now cover whole exome sequencing as a first-line test because of these guidelines. So where we are today when it comes to accessibility for a diagnosis for patients with autism and developmental delay when they come to a genetics clinic has come extremely far within the past decade. So when I talk about exome, or even you hear the word genome versus a gene panel, what am I talking about? So whole exome sequencing is actually looking at all of the coding regions of all of the genes. Whole genome sequencing, alternatively, is looking at all of the coding and non-coding regions of the genes. We have 20,000 genes, but we only know what about 5,000 of them do. The rest of the genes, we know that they're there, and we know that they definitely have a job, but we may not know what their role is when it comes to gene-disease relationships, and I'm going to talk about that as well. So it's a really great test when you say, I want to get basically a panorama photo of the genes. I want to get as much as possible into the picture so I can get a very broad picture and see if there is a genetic change. Therefore, what we like to do when we're in clinic is we like to use what we call a trio. That has the highest diagnostic yield. So the patient presents for testing, they will draw a sample either by blood or a cheek swab, buccal swab for the patient, and then they will do a trio where they compare that genetic information to the parents, because if the parents are not affected, so they don't have any phenotype similar to the patient, then they will actually compare that information to the parents, because we would expect the parents not to have that genetic change, which makes sense. So this gives us a lot of information in context to the patient. It allows for us to reanalyze and reclassify, which is what I'm going to really focus on today. It also allows us to look for multiple diagnoses. So oftentimes for children with rare disease, they have multiple different genetic causes for their condition, which can make it very complicated because you think that it could just be one genetic condition, but it could be multiple. And there's also gene-gene interactions as well that we're still learning about, right? So while we can sequence the genetic information, and while basically anyone could buy a sequencer at this point and put it in their garage, you want people who really understand genetics to be interpreting that information. And it's a tool for gene discovery as well, and it can also be used for secondary findings. Gene panel testing, which was very commonplace and still exists today, that is where you basically would say to the lab, hey, you've assigned gene relationships to autism. I'm going to order a panel of genes that you have designated those genes as important, and I only want you to look at those genes and tell me if there is a genetic change in one of those genes. As you can understand, that's very limited, right? Because it depends on, well, how did the lab pick those genes on that panel, right? And also, as I mentioned, there could be multiple diagnoses. So you could find a genetic change on that panel, but you could be missing half the story because you didn't look elsewhere. So that's the reason why panels have kind of gone by the wayside, and actually the reason why a lot of payers have moved away from doing panel testing, because you would have to order it multiple times because gene panels get bigger over time as we understand more. So exome testing, to be honest, much better, more economical test. So just kind of some heavy hitter numbers. So as I mentioned, the diagnostic yield of exome is between 25 and 40%. That's where we get that 38% number. Really, it depends on the lab and how they're getting to the final answer. Also, that diagnostic yield has changed over time. So as I mentioned, we started doing exome sequencing in 2011. And as the VP of our company said, she was the first genetic counselor who worked on Exome. She thought there was 100% diagnostic yield for Exome when we first started doing it, because really the people who were getting whole exome sequencing at that time were patients who had pretty severe phenotypes. It was very likely to be genetic. So as testing has gotten more accessible over time, that diagnostic yield has gone down, but that doesn't mean that the test is not as good. It just means that there's more people getting tested, and therefore we have a better understanding of what that diagnostic yield truly is. Additionally, there's a much higher chance of us being able to get a new gene-disease relationship over time, because as one of my favorite geneticists says, she says an exome today is better than an exome yesterday, but it's not as good as an exome tomorrow, because it depends on our understanding of genetics, and we learn something every day in genetics. Also, when you're doing gene panel testing, if you are familiar with genetic testing, there's something called variants of uncertain clinical significance, or VUSs. It's exactly what it sounds like. It means a genetic change that we don't know what it means. And the labs need to, in addition to us understanding gene-disease relationships, we need to basically see these genetic changes over time within these genes for us to understand them. So eventually they get reclassified to negative or positive, but you have to be at least 90% sure based off of the way that we score variants before they reclassify them. So we want the labs to be very confident in their classification before they call something negative or positive for many reasons. We don't want people to be going on medications if they shouldn't be, or getting surgery if they shouldn't be, because it's not actually pathogenic. And then I'm going to talk about reanalysis, which that also allows us to get an answer over time and increases the diagnostic yield. So going back to this case example, as I mentioned, the provider ordered all of this testing, and though this patient seems like this is really likely to be genetic, given all of these body systems being affected, her exome was negative at the time of testing. And at most labs, that would be the end of the story. But at Ambry, we do a proactive reanalysis program, and I'm going to talk about how we found an answer for this patient. So we're going to come back to her. So I keep talking about the fact that an exome is only as good as our understanding of genetics at this moment in time. Well, the more we do genetic testing, the more we understand the results. That's because historically, in terms of who had access to genetic testing, we really do not understand the genes of individuals of the non-white ancestry, genetic changes in those genes, or novel genes in those ethnicities as much as in the white ancestry, those patients. So there's a lot of uncertainty. So the more we test people, the more we understand about genetics and the more we learn. Additionally, as we learn more information about gene-disease relationships, about 1 in 3 patients who have a positive result off of an exome or genome have a result in a gene that's been characterized within the past maybe 2 years or so. So that means that you have to order exome at just the right time, basically, or order a reanalysis at a lab, looking back at that data to get an answer. You could miss that answer, and I've seen this happen to patients where they get a test ordered and there's a new publication about a gene 3 months later. So imagine missing a diagnosis by 3 months. That just seems unfair. And there's a new gene-disease relationship characterized every other day. So we learn something all the time. That's through publications, that's through collaborations, that's through programs called Gene Matcher, which I'm going to go through. And this graph shows over time just our rapid discovery of these genes. So how do we understand gene-disease relationships? How do labs qualify this in an objective and quantitative way? So at Ambry, we have our own unique gene-disease validity scoring system. So this is made off of both genetic evidence, which is case reports, cohorts, case control studies, as well as statistical evidence. Experimental evidence, so functional studies are really important. So I know we've talked a lot about some of the research with functional evidence today. That is so important as we're evaluating these genes, and the publications that the researchers are doing even here at the CEVA Autism Center, that's so important, and we use that in the clinical diagnostic space. So we need to keep up to date on all of these publications, as well as the function of the gene. So is it a loss of function gene? Is it a gain of function gene? All of these things are very important because all of that is basically scored. And so there's a numerical scoring system where we assign weight to these different lines of evidence. And so a gene could be a gene of uncertain significance. So in genetics, we like to say it's an uncertain significance rather than, I don't know. So this is where, if it's a moderate or characterized gene, this is where we say this is definitively, we have enough evidence to call this pathogenic. And in fact, limited evidence genes, you will never get a positive result in a limited evidence gene because that gene-disease relationship hasn't been established. So a lab can't call something pathogenic by the American College of Medical Genetics guidelines for variant interpretation. So how does this impact exome testing over time? So as I mentioned, an exome is only as good as our understanding of genetics at this moment in time. And we have new gene disease validity scores characterized, and so therefore we get a better understanding of the mechanism of that disease in patients. And these gene-disease relationships are tailored for variant interpretation. As I mentioned, the more we understand about the genes, the more we understand about the variants in that gene. And that allows us to have proactive reclassifications. So at Ambry, we have something called the Patient for Life program. This is my favorite thing, and actually at the CEVA Autism Center, you've had quite a few patients that have been affected by the Patient for Life program. So at most labs, as I mentioned, you order an exome, you get a report, that's the end of the story. Sometimes they'll allow you to ask for a reanalysis of that data at no cost one time. Sometimes they'll say after that there's a cost of a few $1,000s, or they might say you have to order it within a certain amount of time, or you can't order it until a certain amount of time. At Ambry, we do not think that's fair or accessible to patients getting an answer. We want patients to get an answer as soon as it's available. So therefore, if a patient has a negative exome report, we already have that data in our system. And we have a gene team, and so they are constantly looking at the publications to see, are these genes being upgraded, the gene-disease relationship over time. If that gene-disease relationship gets upgraded, what we actually do is we go back and we say, let's look at every patient since 2011 who had a variant in this gene that we didn't think was associated with the disease at that time. If they have a positive result based off of the information that we now know, then we go back, we look at the data, and we give the patient and their provider a positive result. And that makes the provider very happy because they can call their patient and say, hey, I know you had exome testing 5 years ago, 10 years ago, but now I have an answer for you. And the patient doesn't need to come back to clinic, the provider doesn't need to ask for anything, this is completely free of charge. And then we go back and we look at all of the rest of the patients that had the same variant or maybe a different variant in that gene, and we're able to upgrade them to positive as well. So on average, when we upgrade a new gene-disease relationship, it affects about 9 patients each time. And as I mentioned, these gene-disease relationships happen all the time. There's about 8 new neurogenes affected each month. So it's a lot of patients where this affects. It actually affects 1 in 20 patients who were tested at Ambry, so about 5% increase in diagnostic yield. And we actually found from the data, we talked about the fact that there is inequity when it comes to genetic testing just based off of access to care. And we know that through our Patient for Life program, we actually are more likely to find a pathogenic variant in a newly characterized gene in non-white patients. Specifically, the highest increase in diagnostic yield is in the Black and African American population. So this makes testing and finding a diagnosis more equitable over time, which we are very proud of this data. So back to our patient. Telling her story, she had a negative test, and 2 years later, she actually had a positive result through our proactive reanalysis program in a gene called CDK13. This was new in her or what we call de novo, meaning neither of her parents, both of whom didn't have any of the same symptoms as her. So neither of them had this mutation. This was new in her when the egg and the sperm came together, and therefore it's an explanation for her symptoms. So without having to do anything, she now has a diagnosis. And this 2-year time frame actually really isn't surprising to us at Ambry because new gene-disease relationships, the highest increase seems to be around the 2-year mark after a patient has an exome. There seems to be the highest diagnostic yield for a reanalysis at that time. However, I actually get tagged on every patient for life case when it goes out, and I just had one on Friday where the patient had testing in 2014, and now we have an answer. So that's 10 years. So the 2-year mark is not surprising, that's the highest time period, but it could really happen at any time as we understand more about genetics. So looking at this disorder and looking at this patient, this gene is associated with developmental delay in autism. It's also associated with musculoskeletal abnormalities. It's associated with eye abnormalities. It's associated with feeding difficulties, and most of the time it's de novo. So if we look at this seems to be the explanation for the majority of her symptoms, and she seems to really fit the phenotype that we understand about this gene. We didn't have anything about her facial characteristics noted in the clinical evaluation, but most of these patients have what we call dysmorphic or different facial features because of the change in this gene. So this picture here is not of this patient, it's of a different patient who has a mutation in the CDK13 gene. We also take into account the mechanism of the gene. So most of the mutations in the CDK13 gene were missense variants. So originally when this gene was characterized, we had 6 patients who were affected by this gene disease characterizations because they had a missense variant in this gene. However, we still continue to do gene-disease relationships for the mechanism of disease because we could establish over time through publications and other case cohorts that there can be other different mechanisms of disease that could cause mutations to be pathogenic. So a few years later, 3 more patients actually were upgraded because we figured out that truncating mutations actually also cause this disease as well. So overall, 9 patients were affected by this gene disease characterization over time. So now I'm going to talk a little bit about, okay, so that's great that Ambry's doing it, but what's really important in the field of genetics is sharing data because we don't want things to be happening in a silo. Labs should be able to contact each other, contact clinicians, contact other patients who've been identified through whatever means that they've been found to have a variant in that gene. So we want to connect people so we can learn more about these conditions over time, right? So there's something called Gene Matcher, and this was created by the Center for Mendelian Disorders. And so there's actually 3 commercial labs that participate, including Ambry. And so at Ambry, we have contributed over 250 unique gene disease characterizations, and over half of them are considered clinically relevant gene disease characterizations. So there are some genes of uncertain significance that we've included because we want to learn more about those genes over time. And so when we create a gene matcher entry, we'll basically post the zygosity, we'll take out patient history information so that there's no PHI in there, but we will give the clinical features of that patient. And then other labs, if they have a patient who is tested who has a very similar phenotype, basically they can reach out and say, hey, I saw you submitted something in Gene Matcher. Let's talk about this, our patients, so we can collaborate and we can publish this information and we can learn more about this information over time. And what's great about this is that these 3 labs, so there's something called OMIM, which is basically what we use to track genes over time. It's through the NIH and our understanding of genes and all of the publications. And so these 3 labs have actually added more than 20% of the conditions in OMEM, just 3 labs through Gene Matcher. So it's amazing just what we can do if we collaborate. So you need to make sure that you're using a lab that is doing things to collaborate with other labs and communicating back and forth and contributing to things like ClinGen or ClinVar or Gene Matcher. So who you work with is very important. So as I mentioned, for uncharacterized genes, basically what we do is we create these entries, and we still have the cases in our system. We'll contact other clinicians and say, hey, this is of interest. We really want to be able to upgrade this gene-disease relationship. We establish collaborations, and then we're able to publish, and then we're able to go back, upgrade that gene-disease relationship, and then upgrade all of the patients who have had a variant in that gene since they were tested in 2011. So you can see this is basically a feedback loop, right? So, which is really great, and we've actually published multiple papers about this over time. And this is also the reason why on patient after the patient report, we include opportunities for research as well. So when you're utilizing labs and you're choosing which lab should I do genetic testing through, you want to use a lab that is including these opportunities so that patients also know how they can collaborate over time, because patients, they're the biggest advocates to help us with this over time. We also want to continue to test other people, so there's multiple other touch points when it comes to genetic testing, including familial cascade testing, family planning, as well as clinical studies. So I actually picked this case because there are 2 clinical studies that this patient actually was able to participate in, and we were able to link this patient with these clinical studies. Some clinical studies are just natural history studies, but some clinical studies and clinical trials are actually for treatments of disorders, and they have significant impact on the quality of life for these patients. And so that's the reason why when clinical trials reach out to Ambry and say, hey, can you contact every patient who has a mutation in this gene, we will reach out and we'll contact those clinicians who ordered the genetic testing to let them know that there's an opportunity for their patient, especially when it is drugs that have significant impact on the quality of life. So I really want to thank you all for inviting me to speak today. I just wanted to reiterate the fact that exome testing is a great gene disease mechanism for us to have gene discovery and find an answer for patients. You should be using a lab that is proactively trying to find these answers selfishly. It is what I am most proud of when I talk about Ambry and our genetic testing, because it provides opportunities for patients to be able to connect with other families and participate in clinical trials. And if you don't choose to use Ambry, which there are other labs out there, please make sure that you're using a lab that participates in programs called like Gene Matcher. So I want to thank you for your time today. This QR code is my contact information. So I am an MSL at Ambry. So my entire role is to be here for clinicians to answer questions about testing or results. So please feel free to reach out to me. And my resources are gone, which is totally fine. Oh, thank you. So if you want to look at any of my references, you can choose to do so. And I am right at 45 seconds, so I guess we will do the panel later and you can ask me questions. Thank you for your time.